Welcome back, focused learners, to part 95 of our 100-part CPC exam series. I am absolutely pumped for today's explainer because, wow, we are tackling some of the most heavily tested, high-yield scenarios you're going to face on test day. Before we jump into this CPC exam practice masterclass, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's dive right in. So today, we're setting the stage for a super fast-paced case study masterclass. We're going to take HCPCS Level 2 rules and apply them to high-yield scenarios exactly the way you'll see them under the ticking clock of the real CPC exam. You know, CPT codes, they tell the payer what procedure you did. But HCPCS Level 2 codes, they tell them what you supplied, injected, or transported. And listen, if your modifiers or your unit math are off by even a fraction, boom, your claim is instantly denied. All right, here's the game plan for today. We've got 4 distinct case studies to crush: J-code math, drug wastage with JW and JZ, ambulance modifiers, and finally ABNs and anatomical precision. Let's get to it. First up, case study 1, J-code dosage calculation and units dissection. Okay, put yourself in that test-taking mindset right now. Here's your clinical vignette. A patient receives 250 milligrams of Solamedrol IV. You flip open your HCPCS manual and see that code J2930 has a descriptor that literally says injection methylprednisolone sodium succinate up to 125 milligrams. So the exam's going to ask you, how many units should actually be billed here? Now, here's the trap, and it's a big one. Do not just bill 1 unit just because it was 1 single injection. No way. Instead, you've got to follow a rock-solid 3-step formula. Step 1, identify that total amount administered, right? That's 250 milligrams. Step 2, pinpoint the code's descriptor unit, which is 125 milligrams. And step 3, divide the administered amount by the descriptor amount. So 250 divided by 125 gives you exactly 2 billable units of J2930. Seriously, never guess on these. Always let the math guide you. Moving right along to case study 2, drug wastage modifiers dissection. All right, picture this scenario. A provider opens a single-dose 50-milligram vial of a medication. Your HCPCS J-code descriptor says 1 unit equals 10 milligrams. The patient gets 40 milligrams, and the remaining 10 milligrams? Well, it gets tossed out. So how on earth do you code this? Really think about how you'd separate the dose they actually got from the amount that went into the trash. Well, the solution is like a 2-part puzzle. It requires 2 separate lines. The administered line gets 4 units billed, right, representing that 40 milligrams. Then, on a completely separate line, you report that wasted 10 milligrams as 1 unit, and you absolutely must attach modifier JW to flag it as discarded drug. But wait, what if that entire 50 milligram single-dose vial was used up with literally 0 waste? In that case, you've got to use modifier JZ. It's totally mandatory on Medicare claims to explicitly prove there was no discarded drug. So remember, JW is for waste, and JZ is for 0 waste. Simple as that. Let's keep this momentum going. Case study 3, ambulance origin and destination modifier dissection. Okay, listen closely to this vignette. An emergency ambulance transports a patient from their home, which is classified as a residence, or R, to the local hospital emergency room, classified as hospital, or H. What specific modifier has to be appended to the ambulance base code? Something like an AO429. You know, this matrix is basically foolproof if you just follow the timeline of the trip. Origin always comes first, and destination always comes second. So residence is R, hospital is H. Boom, your modifier is RH. Now, here is a massive trap alert. Do not reverse those letters. If you accidentally pick HR, you're literally telling the payer you took the patient from the hospital back to their house, which is a totally different claim. Oh, and also, don't mix up a nursing facility, which is N, with a private residence, which is R. All right, time for our final dissection. Case study 4, ABN compliance modifiers and anatomical precision. When it comes to compliance, documentation literally dictates financial liability. Imagine a Medicare patient gets a service that we already know is probably going to be denied as not medically necessary. In scenario A, a valid advance beneficiary notice, or ABN, was signed before the service even happened. In scenario B, the provider completely failed to get an ABN. Big yikes. Let's look at the strict difference here. For scenario A, you're going to append modifier GA. This basically tells Medicare, hey, we have a valid ABN on file, meaning when Medicare denies it, the provider can legally bill the patient. But for scenario B, you are stuck using modifier GZ.
That means there's no ABN on file, the claim will absolutely be denied, and the provider is fully liable. They cannot balance bill a patient. Trust me, mixing up GA and GZ is a massive compliance disaster.
And hey, while we're on the topic of modifiers that save you from denials, let's do a super quick rapid-fire review of anatomical HCPCS modifiers. You have to use these for exact site specificity to get a perfectly clean claim. Check out the built-in cheat codes here. It's pretty cool. F stands for fingers in FA through F9, T stands for toes in TA through T9, E is obviously eyelids in E1 through E4, and never ever forget LT for the left side and RT for the right side. If your exam vignette mentions a specific finger, toe, or side, your answer absolutely has to include these modifiers, no exceptions. Okay, let's lock all this in with our final section, the Masterclass Summary Cheat Sheet. All right, let's bring it all together. For J-codes, always divide the administered dose by the descriptor unit. For drug wastage, use JW for the discarded amount on a separate line and JZ when there's zero waste. For ambulances, it's a journey. Origin first, destination second. And for ABNs, remember GA means an ABN is signed and safely on file, while GZ means, oops, no ABN was obtained. Memorize these specific mappings and you're going to lock down those points on test day for sure. Wow, what an incredibly efficient explainer we had today. But hey, we are not slowing down. Up next in Part 96, we're diving deep into compliance, regulatory, and reimbursement guidelines. We're going to break down NCCI edits, the global surgical package, and the critical, highly tested differences between fraud and abuse. But before you go, I want you to really ask yourself, are you fully prepared to defend your claims against an audit? Or is one missing modifier going to cost your practice thousands of dollars? Think about it. Until next time, keep studying, stay focused, and I'll see you in the next masterclass.